Well, I'm Dr. S. Prakash Babu, Associate Professor of Department of Emergency Medicine at SWIMS, Tirupati. In this video lecture, we're going to discuss about damage control resuscitation and damage control surgery. Rethinking the physiology of an exsanguinating patient from the resuscitation bay to the operating theatre. Learning objectives of this lecture include recognizing the lethal triad, how you are going to identify the components of lethal triad, likely hypothermia, acidosis, and coagulopathy, as a self-perpetuating cycle of physiological exertion. How we are going to apply the damage control registration principles, like using permissive hypotension, balanced transfusion, and hemostatic adjuncts at the bedside. Sequence DCS correctly. Describe the three phases of damage control surgery and the goals of each of these phases. And coordinating the trauma team, defining the EM physician's role in triggering and sustaining the damage control registration path. So, how this damage control concept has evolved? As you all know, most of the principles of emergency medicine have evolved from military background. The shift from complete the operation to control the physiology fundamentally changed survivability in major trauma, especially in the military medicine. During 1980s, abbreviated laparotomy has been described with early reports of packing and stage surgery for liver trauma to interrupt physiologic decline. Later, damage control term was coined by Rotendo et al. To formalize a three-phase surgical strategy for the exsanguinating patient. Next comes the recognition of the lethal triad around 2000s. Hypothermia and acidosis and coagulopathy have been determined as the lethal triad that will lead to death or disability in trauma patients, and they have been recognized as two limiting factors, not just surgical technique. In 2007 to the present, damage control registration was born and evolved. Focus has shifted from upstream to the ED with permissive hypotension, balanced transfusion, and early hemodiagnostic support. So, as I already told, the triad of lethal triad in trauma is a self-amplifying spiral. Each element worsens the other two, driving the patient towards irreversible shock. What is the pathophysiology behind this? If the core temperature is less than 35 degrees centigrade, it impairs the enzymatic clotting cascade and platelet function. That leads to tissue hypoperfusion, and ensuring anaerobic metabolism leads to metabolic acidosis, accumulation of lactate leading to drop in pH. This drop in pH further inhibits the coagulation factor activity. All these things combined will lead to consumption of the coagulation factors, their malfunction, and when you start treatment, especially when you are treating the patient with crystalloids, a dilution happens and there is hyperfibrinolysis, increased clot which causes increased hemorrhage, closing the loop. So it's a self-perpetuating cycle. Each element worsens the other two elements. So coming to trauma-induced coagulopathy. Coagulopathy is present in up to 1 in 4 major trauma patients on arrival before a single unit of fluid is given. There are some endogenous drivers which are acute, and there are some iatrogenic drivers which are resuscitation driven. Coming to endogenic drivers, tissue injury releases tissue factor which activates protein C. Protein C inhibits factor 5A and 7A, leading to coagulopathy. There is endothelial glycocalyx shedding, leading to sympathoadrenal autoheperinization. There is systemic hypoperfusion, which drives increased fibrinolysis. There is platelet dysfunction despite normal platelet numbers. So what are the iatrogenic causes that can lead to coagulopathy in trauma? As I described already, when you give large volumes of crystalloids before blood products, or blood products are neglected or delayed, these crystalloids are going to dilute the blood, leading to just increased volume of the blood. It doesn't supply any clotting factors. There is no increased oxygen carrying capacity in the blood. So that worsens the coagulopathy. Then there is hypothermia from cold fluids in an exposed patient. So all these things will lead to development of anaerobic metabolism. There is acidosis from under resuscitation or excess chloride-rich fluids, or delayed correction of energy hypocalcemia during a massive transfusion, or the contributors for trauma-induced. So how are you going to recognize the patient who needs damage control? These are the determinants based on which you recognize the patient who needs a damage control. The temperature is less than 35 degrees centigrade on arrival, are trending down despite adequate warming. Coagulopathy with INR greater than 1.5 or visible non-surgical medical bleeding. Transfusion burden, ongoing massive transfusion requirement requiring greater than 10 units of PRBC in 24 hours. Acidosis with pH less than 7.2 and base deficit greater than 8 millimoles per liter with a lactate of greater than 4 millimoles per liter. Time to control, anticipated surgery is taking more than 90 minutes or definitive repair is going to be delayed, then you start damage control. Mechanism of injury pattern, multi-cavity injury, major vascular injury or complex hepatic trauma are the drivers for activation of damage control. Damage control registration has mainly 4 pillars. We have gone through them already. Permissive hypotension. We are going to limit the crystalloids, accept a lower systolic BP until the hemorrhage is controlled. Then comes the hemostatic resuscitation, wherein you limit the crystalloids and transfuse blood for blood. Lead with blood and blood products in a balanced ratio. Rapid hemorrhage control, identify the sites where bleeding is happening and minimize time to surgical or angiographic control of bleeding. Prevent the lethal triad from happening by either active rewarming, minimal dilution, and early calcium and tranexamic acid. These are the 4 pillars: permissive hypotension, hemostatic resuscitation, rapid hemorrhage control, and preventing the triad are the 4 pillars of damage control registration. Coming to permissive hypotension, the rationale is aggressive normotension before hemorrhage control raises the hydrostatic pressure within the capillaries, which dislodges early clots which are not yet stabilized and can dilute the clotting factors. The target BP of 80 to 90 millimeters of mercury systolic BP in torso trauma with no traumatic brain injury is the norm. Less than 1 liters of crystalloid before blood products, and the patient has GCS of less than 8 or a suspected TBI maintains systolic BP between 100 to 110 millimeters of mercury. So avoid traumatic brain injury or spinal cord injury because it can worsen the brain injury or cause secondary brain injury by increasing edema. So this is about permissive hypertension. Then comes the massive transfusion or balanced ratios. Activate massive transfusion protocol early. Don't wait for the first unit to run out. Use a validated score like ABC, shock index to trigger the activation. Send group specific or O negative blood immediately while typing is pending. Reassess the viscoelastic testing like TEG or ROTEM where available to guide the component therapy. Deliver blood products in a ratio that approximates the whole blood volume. Treat the coagulopathy before it fully develops. So the ratio is 1 is to 1 is to 1. 1 PRBC packed cells, 1 FFP percussion plasma, and 1 part platelets. Where available, low titer O positive whole blood is an emerging first line alternative to component therapy. Then comes the hemostatic adjuncts, the third pillar. Tranexamic acid should be given at a dose of 1 gram intravenously over 10 minutes within 3 hours of injury, followed by 1 gram over 8 minutes. Antifibrinolytics have greatest benefit when given early in the course. Then give fibrinogen support, cryoprecipitate or fibrinogen concentrate when fibrinogen is less than 150 to 200 milligram percent, often the first factor to become critically low. Perform calcium correction, citrate in transfused blood chelates ionized calcium. Check ionized calcium and replace the with calcium chloride during massive transfusion. 10 ml of calcium chloride or 30 ml of calcium gluconate can be given for every 2 units of PRBs that are transfused. Factor concentrates, prothrombin complex concentrates for reversal of anticoagulants or refractory coagulopathy, and a specialist guidance should be used. The next part is the damage control surgery. Damage control surgery has 3 phases: abbreviated surgery, physiologic restoration, and then go for definitive repair in that order. These are the 3 stages of damage control surgery. Abbreviated surgery, concentrate on controlling the hemorrhage and removing the contamination only. Pack, ligate, staple. You don't try to reconstruct the abbreviated surgery period. Target is minutes, not hours. Then comes ICU resuscitation. Correct the lethal triad, rewarm the patient, optimize coagulation, optimize ventilation, monitor for abdominal compartment syndrome, and if abdominal compartment syndrome is developing, treat accordingly. Then plan a definitive surgery once the patient has been stabilized and coagulopathy has been corrected. Plan relook at 24 to 72 hours with anastomosis, facial closure, and formal reconstruction once the physiology allows. Coming to phase 1, the abbreviated laparotomy. Goal is to stop bleeding and the spillage, nothing else. There's no reconstruction, no repair, nothing. Only stop the bleeding and stop the spillage. Operative priorities include rapid entry, 4-quadrant packing to tamponade hemorrhage, ligate or shunt injured vessels rather than formally repair the vessels, staple or clamp bowel injuries, defer anastomosis, control contamination, avoid formal ostomy formation. Temporary closure and handoff. Temporary abdominal closure, for example, negative pressure or backpack technique. Avoid definitive facial closure, minimizes abdominal compartment syndrome risk. Target operative time under 60 to 90 minutes. Communicate clearly with the anesthesia team and the ICU team for the ongoing handoff. Then ICU registration and physiologic restoration is the second stage. Correct the lethal triad before returning to theatre. Rewarming, core temperature of greater than 30 degrees centigrade, warm fluids, forced air warming, warm ventilator gases. Continue balanced products guided by TEG or ROTEM, correct fibrinogen and calcium. Optimize oxygen delivery, normalize lactate and base deficit, avoid over-registration. Ventilation should be lung productive ventilation. Monitor for abdominal compartment syndrome affecting airway pressures. Ongoing survey, serial exams for missed injuries once the patient stabilizes. Return to theatre once the physiology, not the clack, allows, typically between 24 to 72 hours. DCS phase 3 is the definitive surgery. The goal is complete reconstruction once the patient can tolerate it. Planned laparotomy, remove the packs, re-inspect for missed or evolving injuries. Perform definitive bowel anastomosis or formal ostomy as needed. Formal vascular repair and reconstruction where earlier shunts were placed. Attempt primary facial closure if not possible. Staged closure or component separation. May require multiple sequential returns to the theatre depending on the injury burden. The question is, why not close the facial planes immediately? Early forced facial closure under tension raises intra-abdominal pressure and risks abdominal compartment syndrome, compromising renal, respiratory, and splanchnic perfusions, reversing the gains of phase 2. So you don't go for forced closure. Only when closure is possible, you will close. That's why patient might need multiple returns to the OP. How do you make decisions? Indications and relative contraindications for damage control surgery. Consider damage control when there is inability to achieve hemostasis by direct techniques. Major venous injury requiring complex repair, for example, retrohepatic vena cava. Need for non-operative management for a second injury simultaneously. Physiologic exertion, triad already established intraoperatively. Combined vascular and hollow viscous injury with gas contamination. Damage control registration already required preoperatively. Reconsider or proceed with caution if the patient is having physiologically stable and injuries are unable to definitively repair within a reasonable time period. Isolated, easily controlled injury with no coagulopathy, no ICU capacity to support staged management, escalate transfer early. Damage control is a strategy, not a substitute for hemorrhage control skill. Use judgment, not checklist alone. What is the role of Rebova and other bridging techniques? Tools that buy time for trauma team while definitive control is arranged are called bridges, not destinations. Rebova, also called a restative endovascular balloon occlusion of the aorta. Zone 1 is supraciliac aorta for intra-abdominal hemorrhage, and zone 3 infrarenal for pelvic hemorrhage can be occluded with a balloon. Temporaries flow proximal to the injury while access to definitive control is being prepared. Application of a pelvic binder or external fixation reduces pelvic volume and stabilizes fracture-related venous bleeding as a first line, low risk adjunct in suspected pelvic fractures. Resuscitative thoracotomy reserved for peri-arrest patients with signs of life, predominantly penetrating thoracic trauma with witnessed loss of vitals, allows aortic cross clamping and cardiac control. Interventional radiology, angioembolization for solid organ or pelvic arterial bleeding, often used in conjunction with or after damage control surgery, can be used. What is the role of emergency physician in DCR DCS pathway? Our role is mainly recognizing early patients who are in need of DCS or DCR, identify physiologic markers of lethal triad within minutes of arrival, activate the team, trigger massive transfusion protocol, and mobilize surgical and anesthesia teams simultaneously. Resisted in parallel, begin DCR, permissive hypotension, balanced blood products, and adjuncts like tranexamic acid without delaying transfer to the theatre. Communicate effectively and hand off the patient to the ICU. Give a structured handover, ensure ICU is prepared to continue phase 2 registration. What are the common complications and pitfalls of DCS and DCR? Most feared dreaded complication is the abdominal compartment syndrome from over-agitation or premature facial closure. Monitor bladder pressure and airway pressures closely to detect abdominal compartment syndrome. There is chance of missing important injuries. Abbreviated first look surgery can miss secondary injuries. Mandates a thorough relook and ongoing tertiary survey. Over-resuscitation with crystallite can worsen the dilutional coagulopathy and the tissue edema. Discipline around blood product first resuscitation is essential. Delayed recognition, waiting too long to commit to damage control allows the lethal triad to become entrenched and harder to reverse. Enteric and vascular fistula, risk with prolonged open abdomen or repeated re-exploration, balance need for source control against tissue trauma. Packing related ischemia, overly tight packing can cause visceral or vascular ischemia. Reassess and adjust each take back. Key takeaways in today's lecture. Damage control is a physiological strategy, not merely a surgical technique. It begins in the resuscitation bay. The lethal triad of hypothermia, acidosis, coagulopathy is a self-perpetuating cycle. Prevention outperforms correction. Permissive hypotension and blood product first resuscitation limit dilution and preserve early clot. Surgery proceeds in 3 deliberate phases: control, restore, and then reconstruct, when timing driven by physiology. Early recognition and team activation by the emergency physician are the single greatest determinants of outcome. So I used these references: Rotendo, Holcomb, Crasto collaborators, Johnson Jevo, American College of Surgeons Committee on Trauma, and Dixon et al. Damage control registration, combining with damage control laparotomy as survival advantage.